So let's go a little more into the anterior cases. To give support to this, we made a lot of basic research, and so I had the privilege to work together with Professor Adriano Piatelli from Italy, and we conducted these animal studies in my university. So in these studies we compared external hexagon with cone Morse implants, and also we did 6 experiences in one study. We're conducting now several other studies in the same direction. And in this study you can see the implants placed. You can see the placement is a little deeper than regular in the dogs. And we followed the situation along 8 weeks to find out at your left side now at the radiograph, you can see the bone situation immediately at the insertion of the implants. At the right side, you can see 8 weeks after, all these implants were immediately loaded. And you can see in the middle, you have a classical external hex implant. If you compare the 2 radiographs, you can see the bone remodeling or bone loss around the external hexagon. Now look at the 2 cone Morse implants, and you will see in this study what we found out was whenever we use a deeper implants or deeply placed implants, we had a better behavior of the bone, a better maintenance of the bone. The most interesting conclusion we got from this study, first we were trying to test the surface. We found out that we tested many experimental surfaces, and now these implants come with a very nice double treatment. Actually, it's a classically known surface. We had blasting, zirconia oxide blasting followed by a sequence of acid etch. And what we found out, this is a very beautiful specimen processed at the University of Chieti together with Professor Piatelli. And we can see here the evidence of bone formed in direct contact with the implant. But that was not the main aspect of this research. The best thing we found out was that actually this is not a completely finished study. We're still processing the specimens in Italy. But in most of the cases, we had this beautiful image of bone on top of the implant at the buccal side of all cases. So that changes completely one of the things we thought in classical implant dentistry. So what about extracting teeth and placing implants immediately? Should we do that or should we not do that? So we're seeing a lot of discussion in the literature, like the group from Switzerland by Dr. Daniel Buser thinks we shouldn't do this. The group from Sweden also by Dr. Jan Linde, Professor Jan Linde, also thinks we should be very careful about placing or not placing implants in the same appointment as we extract teeth. Our conclusions lead us to think that if you use a specific platform switch cone Morse design, I should point out that platform switch doesn't mean the same for every kind of implant. I think the idea of platform switch is very smart and very effective, but in my opinion, platform switch should come together with absolute lack or absence of micromobility. And that's why I think you need an internal Morse taper connection. So you can change the dimensions of your platform, and together with this you can have a very, very stable junction that suffers no movement, and then you can allow bone to grow on top of your implant. So I think this image here, you can see beautiful bone on top of the buccal surface of an implant which was placed in an immediate extraction socket and was immediately loaded. And we have consistent results in this specific protocol, which we'll be able to publish by the end of this year. So I hope that with this we can contribute to a better understanding of how to deal with our aesthetic extraction and immediate placement of implants. So in many of these cases, we do the same protocol, and we end up, whenever you place the implants a little deeper, you end up with a lot of bone apparently in contact with the abutment. Of course, we were very much concerned with this aspect. Look at this beautiful vertical result. If you look at the aspect of the papilla, if you look at the gingival contour, but when you look at your left image, you will see that there was some loss of vestibular or buccal volume, and that might be a concern. Maybe not a big issue in molars or premolars, but when you think about canines and lateral incisors, or especially when you think about very young patients, that's one of my main concerns now. In Brazil, or I think everywhere else, we're more and more placing implants in very young patients. This is a 26-year-old girl. She had just lost her first molar. So look at the situation at when I was trying her metal ceramic crown. Of course, we could talk about metal ceramic, pure ceramic, metal-free, but look at the situation. What should I think besides placing an implant? I have to think that this situation, I have to create an aesthetic situation, and I have to be able to maintain this situation for how many years? Should I say 26-year-old she is, so I like her to have the situation for the next 70 years maybe. Am I able to create aesthetics or to create a stable situation in order to guarantee to a patient 70 years? That's present implant dentistry. So look at the tooth that was extracted. Look at how beautiful the implant is. This is now after 40 days. Look at the remodeling of bone. Look at how deep it was placed. And I believe, and we all believe in our group, that because of the deeper placed implants, then we have bone in contact with the abutment. So this is the initial clinical situation. You can see a huge opening of this socket. Look at the lesion in this extracted tooth. And then you can see the placement of the implant. Let me go back a little here. Placement of the implant, and we always choose not to remove the radicular septum, because then you have a much more predictable initial stability. Then you have a large buccal room. Actually, Danny Starno recently taught us not to worry about the distance between the implant surface and the opening of your socket, but how about the possibility of losing all this volume and ending up with a big aesthetic problem? So we're now grafting most of our situations to try to create a situation in which we have slow resorption, slow remodeling. We do our provisionals with this interesting protocol. Those provisionals will be, we call it the prosthetic sealing of the alveolar process. So actually do our provisionals. You can see the abutment connection, which is very narrow, but we do our provisionals with a very carefully controlled contour in order to be able to softly touch the whole opening, and then to have a very good adhesion with the soft tissue. And you can see immediate placement of the implant. We already have some buccal loss. You can see it now 60 days later. Look at how beautiful 90 days later, and now you still have a very nice preservation of the buccal aspect. And look at how interesting it is, because one of the concerns that a lot of people had in the past was, whenever I place an implant in an immediate extraction socket, I'm going to have some vertical recession. We managed to completely solve this problem. Actually, in many of our cases in which we use cone morse implants, we have even a coronal positioning of the final tissue, which is great because then you can just press it a little. As soon as you can place your implants deeper, you can also place the prosthetic margin a little deeper, so you have a lot of space to deal with this. So I think these, which were the more critical aspects in aesthetic implantology along the last 15 days, are quite solved. Now we have to take care about the color of the tissue and about the maintenance of the volume, buccal volume of this tissue when you do extraction, especially in those patients that have high smile lines. So look at the situation now in the final metal ceramic crown. A very beautiful and stable situation after 1.5 years. And that patient actually changed a little bit my opinion, because I think that from now we have to be prepared to do implants in very young patients. So going to our last cases, let's go to the anterior region. And of course I should admit that when you do anterior cases, you have really to look carefully at the characteristics of the soft tissue. Of course, some patients have a very favorable U-shaped soft tissue, and some other patients have a very unfavorable and prone to recession, V-shaped, thin soft tissue. So taking that into consideration, the protocol that we use is always we do extraction and we plan to do the immediate placement of the implant. In all cases, we try to not to open a flap. I'm very much aware of the recent articles published by Mauricio Araújo and Ian Linde, in which they found no difference between opening a flap and not opening a flap. But that's actually not our clinical feeling. I understand that under the scientific conditions of the experiment, they found no statistically significant difference. But we find out, and we have interesting reasons, since the classical studies by Rubin and by Goldman back in the 60s, in the classical periodontal studies, when they would open a flap in an experimental dog model, they would just raise a flap, wait for 15 minutes, place it back, and that would cause a 1 to 1.5 millimeter recession. So we find out that not to open a flap in our clinical follow-ups is much better than opening a flap. So we try never to raise this flap. This creates another concern: how to sometimes graft the buccal aspect of the buccal plate without raising a flap. So we place our implants. We really do not care anymore about how much space do we have between the implant and the buccal plate. The better, the biggest, the better, because we are going to try to do the perfect protocol like this. We place the implant at least 2 millimeters deeper than the buccal aspect of the bone crest, and we stabilize this implant as best as possible. That's why we need good thread designs in our implants. Then I do this clinically important provisional crown that will have this very precise contour. It will fit the abutment, but especially it will have a contour in order to perfectly close the opening, softly touch the opening. Another concern will be the clinical preference of many prosthodontists to take an impression directly from the implant. That's why in this implant that I participate in as a consultant to this Brazilian company, Neodent, I really participate in the design. One of the discussions I had, do we really need an indexation inside the implant? So we use not to have an indexation. But if you don't have an indexation, it will be very difficult for the prosthodontist to take an impression of the top of the implant and send it directed to the lab, and the problem will be to reposition the abutment and the crown when it comes from the lab. So it's a nice idea to have the indexation, but we really have to research, to investigate a little better in the future what would be the consequences of removing and replacing. And how many times can we do this? It seems in our studies that if along the first 90 days after insertion of the implant, there's not any significant problem if you remove a healing abutment and then place the final abutment. Or if you make a mistake during surgery, you don't like that abutment, you want it a little deeper or a little larger, that's not a big issue if you change it once. But we have a very good indication from literature that making this a lot of times will probably induce some recession and bone loss. So we do this provisional crown, and here you can have a brief idea on the technique, on the options of techniques. This is a beautiful video produced by our people from Neodent, and you can see the very delicate extraction of the tooth. That's the protocol that we believe would be the adequate protocol for the remotion, the extraction of a condemned anterior tooth, and then placing the immediate implant. Whenever you do the extraction, you will end up with two possible situations. In one case, you have a completely preserved buccal plate. In the other case, you have a destruction of the buccal plate with more than 4 millimeters when you consider the vertical measurement. In this case, we really suggest you to do a step-by-step regeneration and reopen it after what is indicated by literature. But whenever we have less than 4 millimeters of buccal vertical bone loss, we believe that you can very safely anchor your implant in the buccal plate. It's not a big problem to the amount of space that you will have between the implant and the buccal plate. So we are using 3.5 cone Morse implants, because then we have more room at the buccal area. So we just place our implants, carefully place in order to have at least 2 millimeters deeper than the buccal plate. We can choose between an anatomical abutment or a custom abutment. It depends on the preference of the prosthodontist. But of course, if you have an anatomical abutment, it will be much easier to perform a provisional crown in order to fulfill our suggestion, which is have your provisional crown completely touching the surroundings of these socket opening. So then you go to your final crown, and if possible, you shouldn't change this abutment. Next suggestion would be to use a standard abutment. In this case, for this universal abutment, it's easier because you can take impression, you have analogs, you have everything in order to do it easier. But in this case, the only problem would be that you would have to have a little more of effort when doing your own provisional crown. So the prosthodontist has to like doing this in order to, do that as a perfect, well-done provisional crown. So you can briefly have an idea in these beautiful drawings. So you just take your tooth out, place your implant anchored in the buccal plate, place your abutment, and then do your provisional crown in a way that you can have a concave surface of the provisional crown inside the wound and a convex peripheral contour of your crown in order to completely seal the opening of the extraction. Then you can take a look at this specific case results after 5 days. You can also have an idea of the radiographical aspects, and then you can see a nice soft tissue which was absolutely spontaneously obtained. Nobody needed to do anything with this soft tissue. It just obeys. Actually, with the provisional crown, you shape your soft tissue. And in this case, is when you have very, very nice soft tissue quality, you don't even need to be very much concerned about the buccal loss of volume. And you end up with this beautiful papilla, beautiful soft tissue, and especially because of the Morse connection, you have no signs of inflammation. You have a very, very high quality soft tissue. So these are the protocols that I would like to have discussed with you. Based on this, we can use also zirconia and all this new technology abutments in order to immediately place implants and end up with very predictable, beautiful, soft tissue aesthetics, and also the use of these nice, newly developed zirconia abutments also create to us the possibilities of using all the very nice effects and translucency, fluorescency, opalescence, and high aesthetic quality that the modern ceramics offer to us. The Morse-taper connection gives us a very, very stable bone situation along ears, and the consequence of a stable bone situation is also a stable soft tissue and the long-term endurance of our aesthetic results. So dealing with young patients, placing our implants a little bit to the buccal, being careful a little bit to the lingual aspect of the alveolus, being careful about how to deal with the buccal volume of the tissue will be probably the issues we are going to have to work hard along the next 2 or 3 years to be able to completely solve. So I hope you appreciated that, and I hope you can also share in the future beautiful aesthetic cases.